So Dr. Ben Anderson is a professor emeritus of surgery and global health and medicine at University of Washington. He has worked in global cancer control for over 25 years. And to start, Dr. Anderson, I'd love to ask you about, I know you led the launch of the Global Breast Cancer Initiative at WHO. Could you tell us about how that started?
Sure. Well, thank you. First of all, Joe, thank you very much for including me. This is really a very unusual and interesting time to be addressing cancer. So much is changing. Um, but you're right, that the Global Breast Cancer Initiative, GBCI, that was launched from WHO was WHO's initial effort into comprehensive breast cancer care. We launched the program in 2021, and in 2023, we launched the framework, which is essentially a how-to manual focused on limited resources. But if you back up 20 years, that a group of us had been involved in breast cancer care in a grant by USAID for Ukraine. And it was in this Ukraine program that a group of us both became interested in global health, but also came to understand how little we understood. Because at that time, back in the late 90s and early 2000s, the thinking was, gosh, you can't talk about cancer care in Africa. That's not realistic. And the thinking was very simplistic. Well, we must just reproduce what it is you do in high income countries, in low and middle income countries. And if you can't do that, then it's not going to work. And what we said, we looked at these issues and we said, we don't think this is right. We think that actually there are things you can do and they are meaningful, and it is based upon existing resources. And so the program that I led from the University of Washington and Fred Hutchinson Cancer Center was called the Breast Health Global Initiative, BHGI. And what we did was we pulled together experts both domestically and from around the world to analyze these different aspects of what are the issues, what stops care from working well, and what do you need to do in a systematic way. And breast cancer is a great model for understanding cancer. It's the most common cancer globally. It is the most common cancer among women. It's the most likely reason a woman will die of cancer globally. And so it has a very big impact that with the number of breast cancer cases that are out there, there is no Ministry of Health that could address cancer and not talk about breast cancer. It's too big. So it's both a disease that needs to be managed, and it's a pathway for addressing bigger pictures, because not just breast cancer, because it's the same infrastructure that supports that supports breast cancer, that also supports colorectal cancer and lung cancer. It's all part of a bigger system. It's just that breast, we know so much about it from our studies that we can piece together functional systems. And that's really what this work was about. We held 6 global summits over 18 years, addressing progressively more integrated thinking. This all preceded my going to WHO. And we developed this idea of resource stratified guidelines, which is resource stratification means that you know all the pieces that are there, but with resource stratification, you prioritize. What are the essential elements that need to be in place? What do you work toward as the next steps? How does this evolve over time? And it really was a great setup for what became the Global Breast Cancer Initiative at WHO. I'm very excited to see how this goes forward.
So I'm curious with the resource stratified guidelines. I wonder if you could talk about how that breaks down in terms of thinking about prevention, detection, and improving outcomes. And is that the right set of frames, thinking about preventing, and then also what you do after you detect a cancer, and specifically breast cancer?
Sure. Well, so you raised 2 questions. One was about resource stratification, and the other was about where do we interface? And you specifically brought up prevention. And obviously, prevention is ideal. If you can stop cancers from occurring in the first place, That is the best result. And that's why tobacco control is so helpful and relevant. In many ways, it's kind of the low-hanging fruit. That it's one of my colleagues used to say, tobacco is one of those few products that when used as directed, it kills you. And we really don't have therapeutic uses for tobacco and tobacco products. But when you start talking about solid tumors, breast cancer, colorectal, lung, melanoma, it's more complicated because while prevention can play a certain role, once the cancer starts, you have to treat it. And so if you look at prevention, we do have risk factors that we know are relevant to breast cancer. So obesity and physical inactivity, alcohol consumption, and these are associated with higher breast cancer risks. But if you ask the question the other way and you say, well, let's imagine everybody did everything that they were told to do. They became physically fit. They took care of their diet. They addressed exercise. They stopped drinking alcohol. What percentage of cancers would be avoided? It might be as much as 20, 25%. And that assumes that everybody does all those things they're supposed to do to be healthy. And I can't speak for you, but I don't know that I'm always good at that. But the point here is it is a fraction of the cancers that occur that could be prevented through risk factor modification. The significant majority are going to occur anyway. And that's why we need this system. And the way we did this, it was modeled after the Breast Health Global Initiative work. We said after prevention, if prevention, we of course we educate and we do the things that we can do where prevention could be helpful. But then after that, we focus on 3 pillars: early detection, finding the cancers when they are treatable; prompt diagnosis, and this was a big missing piece. You have to figure out which one is cancer and which one isn't cancer in a reasonable period of time. And it's not just easy and automatic, it's a system. When you go to a breast clinic, this is what they do. They go through diagnostic processes to figure out what you've got. And then the third pillar is treatment. And it's not just starting treatment. Finding the cancer early doesn't help you if you don't treat the cancer effectively. You're just finding out the news sooner. But making this work and organized, that's really what our work focused on. But here's a tricky part that I think is important for people to understand, because the question, well, how do you fix cancer? How do you address cancer in limited resource environments where they don't have things? And here's the hard part, you cannot fix cancer from the outside. You cannot helicopter into a country, fix cancer, and leave. You have to have a functional infrastructure left behind. Cancer has to be addressed from within. And so you might use donated funds, for example, to buy equipment, but you cannot sustain all of healthcare with this. So what this is really about is helping countries create sustainable systems that will still make the pieces go together in those 3 pillars. And that's really the hub of this thinking. And resource stratification is where you prioritize. So some things we have are very expensive. Some things are pretty cheap. Some things will achieve very significant benefits. Many of our drug therapies fit in this category, the systemic therapies. But you can prioritize for some of the medicines that are less expensive, that we already know are effective. And so it's about building functional systems with the resources that you have in ways that are sustainable and will continue to function 10 years, 20 years down the road. But it's providing guidance to the country. The country has to do the hard work and the heavy lifting.
So within that resource stratified guidelines and using those 3 pillars as a frame, what's the delta or the difference look like between a high income country for example, for early detection versus a low-income country, given the resource stratified guidelines that you mentioned?
So what resource stratification allows you to do, it allows you to identify where your gaps are. So you list the resources, you prioritize them, and then in a given situation, you can identify what's the missing piece, that because what we're really doing is following the patient, a patient pathway through this system that they're going through, and we're tracking them to see, are they getting everything that they need? And the resource stratification allows you to make some decisions, but about how to build. So when we started doing resource stratification, people said, you can't do that. You're certifying substandard care. And we said, no, no, that's not what this is at all. What we're doing is we're identifying steps that you go through. If you're climbing a ladder, you have to have the rungs a reasonable distance from each other to make it up to the top. And it's by identifying that resource stratification helps. But then ultimately implementing it is up to the Ministry of Health and the healthcare system to identify what works within their structure.
So it's kind of a roadmap for countries to go from virtually nothing to the highest levels of care. Is that accurate, or?
You're exactly right. It helps identify a roadmap where you can build your infrastructure over time, anticipating changes that are going to take place. So, for example, an example that people are very familiar with is mammographic screening. So in the United States, breast cancer mortality was unchanged from 1930 up to 1980. That it was, mortality curves were absolutely flat, even though we were making all of these developments. We developed new therapies, but we also developed early detection strategies using mammography. And now that in high-income countries, we do mammographic screening, following guidelines every 1 to 2 years for ages. And there's arguments about, when do you start? Do you start at 40? Do you start at 45? Do you start at 50? When do you start? But the thinking had been, well, you have to do that mammographic screening because that's what worked. But when you go to Africa and you see how advanced these cancers are, these cancers, you don't need a mammogram to see most of the cancers that present because they're visually obvious. So you didn't need the x-ray. In fact, the first time I went to Ghana in 2004, I asked the surgeons, do you get a mammogram before you operate? And they'd say, no. Why would I? What would I need it for? And actually, when women are coming in with these large tumors that are taking over most of the breast or perhaps eroding through it, they're not ready for mammographic screening, even if you had the resources. And mammographic screening, part of our work was to show, actually, that is a late development. You have to begin with public education and professional education so that women, when they have small lumps, know to come in to be evaluated, and the system is prepared to receive them. It's really about the creating the fundamental infrastructure that we have had here in the US and in Western Europe and Australia, that we're developing these systems that we assumed were there because they were a common part of the health system. It's really about health systems.
So are there countries that have kind of gone up the ladder, or taken the roadmap and progressed significantly, where you can point to and say, these are policies that we want to see more lower income countries do to get to higher levels of care?
Yes. So let's use screening for breast cancer. So a lot of the high income country experts in the early 2000s assumed that you would set up mammographic screening. Well, mammographic screening is relevant for women, let's say ages 45 to 74, if you have the resources to create screening programs. And there's a lot to it. It's not, the mammographic equipment is the easy part. It's the how do you make it work and functional that makes it challenging. But that doesn't tell you anything about what to do for young women under 45. And that's true in the US as well. And that's why building the system so that the women are coming in and seeking evaluation and understand why they would do this, that has to be in place before mammographic screening is there. You asked, are there countries that have succeeded? The high income countries, 1990, breast cancer mortality was at a peak, and it's been dropping by 2 to 4% per year since 1990. And we recognize it's this combination of finding the cancers earlier and providing that comprehensive therapy. That's what's making this happen. So what's happening in low and middle income countries is they're not yet seeing the mortality benefit. And we didn't see it right away either. We started mammographic screening in the early 80s. It was not till 1990 that mortality started to drop. So what we're seeing is, and what I anticipate will continue, as these programs develop, we will, and they build upon themselves, we'll see the number of cancers go up, but we'll, at the same time, there'll be more of these early stage cancers. And the early stage cancers are the most treatable, most likely to get good results, most affordable to treat. So there are multiple reasons why this is called early diagnosis, finding them before it has a lump or something that you can see. And it's getting ready for mammographic screening. But you don't start there. You don't start by running a 26-mile marathon. You probably start by walking around the block a couple times, and you work your way up. And this is really about health systems and how they function. Realizing when we do it for breast, there are going to be side benefits for other chronic diseases, other cancers, and other general health issues that are so important, like diabetes and cardiovascular disease. It's about building the system.
So you mentioned the cases of or the number of cancer would go up. That's really just because it's being detected for you're getting the detection numbers that you wouldn't have otherwise gotten, right?
That's exactly right. And this is a good example of something that people had not anticipated until we really started to look at the numbers. But when you have very little detection issues, the only cancers you'll see are the most terrible ones that are so advanced, and the poor woman is miserable, and those are the ones that will make it to the hospital. But the early stage lumps that don't really hurt, those are the ones that don't come in. So when you start early detection, people thought, oh, well, won't the numbers of cancer go down? No, it goes up. We did modeling for the country of Kenya. We had funding from the World Bank. And the model shows that in Kenya, the number of breast cancers when they start the early detection programming, which they're working on now, the number of cancers that require treatment is going to about double. And the Ministry of Health needs to know that the numbers go up before they come down. And this is exactly what happened in the US and Western Europe. It's not a surprise or new information, but incidence goes up, but more early stage cancers. Treatment, when it's effectively provided, that's where we start to see the reducing breast cancer mortality at the population level.
So you mentioned like building these systems, and you just mentioned the World Bank and Kenya. What's the role of organizations like the World Bank or the World Health Organization, or large philanthropic organizations? What's their role in getting things going versus, or in addition to, the Ministry of Health in a given country?
It's a great question. And I think what I would say is that in terms of oncology, we are at a time for all hands on deck, because there's plenty of work to do and plenty of contributions to be made in different arenas. So, for example, in the political arena, political will turns out to be very important. And if you look back historically in countries, they start doing cancer work because somebody got cancer. In Ghana, they started breast cancer work before they started cervical cancer work. And this probably was because the first lady of Ghana got breast cancer, and it heightened the awareness. So the advocate groups they play an important role because they communicate to the ministry and say, as a public, this is what we want. This is what we need. And that's part of what creates political will. So advocacy not only is important for education, but also for driving political will. We have industry, and industry, I must say, they have evolved a lot in the past 20 years. I've watched it and have been quite impressed by it. When I first started doing this work in the early 2000s, Ghana 2004, the pharmaceutical companies had some presence in Ghana that I saw, but it was a very simple model. It was essentially a market strategy where they were making medicines available for free. This is what would work in the US, but they weren't asking the right questions. Like, if I give you an anti-estrogen, if I give you tamoxifen or an aromatase inhibitor that works on estrogen receptor positive cancers, you can only use it if you have estrogen receptor testing. No one was asking the question, do you have the test that makes the drug relevant? And so that was an example of these things that we had to work our way through. Industry now plays very significant roles, and in building infrastructure. And I can't say that I have an insider perspective, but I think it's smart, because if you're really going to expand markets, they need to have an infrastructure that makes your product relevant. Think of the number of people in India that could benefit from the products that we have, but you have to have the infrastructure there. And academia plays a role. That's where I came from. I think it helps on the guideline decision making. You know, if I do A, what can I expect the result of A will be? And if I don't see that result, what study do I do to figure out what went wrong? And it's really about establishing these general approaches, that working with people from inside the country. I worked at WHO for 3 years, and I left in 2023. And for a year and a half before retiring, I worked for an NGO, a non-governmental organization called City Cancer Challenge, CCAN. And what CCAN does is they focus on individual cities. So in Tbilisi, Georgia, that's the capital of Georgia, there's work done at the city level that, because a city is confined, you can track patients and identify where they go. That's hard to do at a national level. So by developing models that worked in cities, this creates appropriate strategies that could be ramped up to the national level. But what needs to be understood is there is no one size fits all. You have to adapt to your environment. You have to adapt to the situation and identify, where is my next step? Where's my next opportunity? And how can I do this in a way that is sustainable? And everyone plays a role in this.
Yeah, I'm curious. You mentioned pharmaceuticals and academia. What are your thoughts on like the research and development that we should be focusing on right now as a society, and also how it is maybe more of a cross-sector collaboration to get the things that countries need quicker?
So the R&D, the research and development question, is really important. And it's interesting, because if you look at what we've done over the past 20 years, research and development is largely focused on the cutting edge care. It's the new medicine, these targeted therapies, these biological therapies. These are really important, and they're making big changes. They also are unaffordably expensive. So, but the focus has been on that, tweaking the system to make it a little better, a little better, a little better. In the low and middle income country settings, that isn't really the research that's needed. The research that's needed is health systems research. What works, what does not work. And the idea of implementation research is, instead of a tightly controlled trial, which is a good test of a tool or a medicine, that they do these implementation research projects where you do a programmatic intervention with all its messiness, and then you see what actually happened. It's very real world application. And that's where you start to figure out where the gaps are that you might or might not expect. For example, understanding culture, understanding social beliefs. If you'd asked me in 2005, what's sociology, I probably would have said, I don't know. It's kind of gushy. I don't really know what it is. And I now realize that that was a naive perspective of my own. And because if you don't understand how people are thinking, then you will you'll make mistakes in terms of assuming what they will do next. So for example, cancer fatalism is a big problem. Cancer fatalism, if you've never met anybody that survived cancer, and you think cancer, I mean, if you get that, you're going to be dead. Well, why would you seek out early detection? What would the point of that be? But you have to understand their frame of reference. And remember, there are things that we do. We have our own social beliefs. So take mammographic screening. The woman says, I'm fine. I feel fine. No lumps. As far as I can tell, my breast is great. We say, okay. We take her breast, we squeeze it between two cold plates, we get a picture of it, and then we say, ma'am, we know your breast felt okay, but actually there's something here. And we're going to cut it out, and then we're going to radiate your breast, and then we're going to give you medicine that makes your hair fall out. But by the way, at the end of this, you'll be better. It's not hard to understand why someone would go, what are you talking about? I feel fine. So you're telling me that I'm fine, but somehow you're going to make me better. That is our own social belief system. And it's very interesting as we look at the current administration that's being led by someone who questions the whole scientific infrastructure. Here, we're actually seeing it happen, I'm disappointed to say, at a policy level. And because of this same failure to where is science, where is the data, and what do we do with it, proves to be very important, very important.
Yeah, so I wonder if I can follow up on that and ask you, like, what do you see based on the reality that we're living in right now? What do you see the next 3 years looking like? And then maybe a longer term horizon, what do you see maybe more optimistically on the 10-year time horizon in terms of global cancer control?
I am tremendously concerned about the impact that the U.S. administration is having on global health. It's intentionally destructive and disregarding some of the great strengths that we have. Some of our data systems where we collect information on what's happening, those are being disassembled. And the saying in science is, if you can't measure it, you can't change it. Mm. So stopping the measurement of what has been shown to work, whether it be in cancer or vaccines or cardiovascular management, I'm of course very concerned, and I don't have any insights other than to say that I think we need to continue to push and identify where to go. The American healthcare system is that, we've been spending 18% of our GNP on healthcare, which is unaffordable, unsustainable. We do not have a sustainable medical model in our current approach, in my opinion. And so we may see, if there could be a benefit, it would be in helping identify where were those gaps, and are there things that we could do so that the funding is spent more effectively. But the next 2 to 4 years of politics is going to determine a lot of this. Let's step away from that. Imagine this wasn't happening and we didn't have the defunding of WHO, which was fundamentally irresponsible on the part of our administration. But where do we see this going? I see gradual progress being made. And the work that we did at WHO in launching the Global Breast Cancer Initiative Framework, and the work that we did with City Cancer Challenge in developing city-specific plans that based upon the patient pathway, those tools will be the same 5 to 10 years from now as they are now, because it's based on the biology of the cancer. It's the cancer that determines these things. I think the tools will be ready as people come back to these efforts. Cancer is not going away. Cancer doesn't care about your political affiliations. And so I do believe that there will be opportunities after we get through this period of where the NIH, the National Institutes of Health, and the National Cancer Institute are threatened. Their very survival is threatened by what's happening. So I am hopeful that we'll find our way through this. I think we've got the background, and it is going to be a matter of how it fits together in a piecewise fashion.
Yeah. Well, I appreciate you taking the time to talk about all this, and I want to be hopeful as well. So thank you for sharing your wisdom with us, and I hope we can continue the conversation down the road. But thank you again for your time.
Thank you very much, Joe. It was a pleasure being interviewed, and I appreciate what you're trying to do. You're communicating about this is actually an essential step, communicating with the public about what's really happening. So thank you for what you're doing.